Hello everyone, I'm Bronwyn from PACOP. Today we're going to discuss the phase. So the phase is one of the 6 tools that is used in the PACOP suite of assessments. It's only used in the outcomes collection. It's used to describe the clinical situation of the residents and their families, and it is about looking at the suitability of their current care plan. So when you're using the outcomes collection and you're working with phase, it's a clinician-rated tool. There are 4 phases. They relate to the resident and family care needs. They do not relate to illness stage. They're also not sequential. The phases are allocated after a comprehensive assessment using the Outcomes Full Clinical Assessment tool. And once you've done that, you will be able to determine what phase the resident is in and their families. So the 4 phases are stable, unstable, deteriorating, and terminal. If someone is in a stable phase, this does not relate to their illness trajectory. This relates to their care plan. It means that the care plan is working. The care plan has met and addressed all of their needs. The interventions are all working. So it's a good place to be. Think steady. If the person is in an unstable phase, it means to say that all the interventions and anticipatory needs that you have put into place for the person are no longer working. In this situation, the person would require a review. Think urgent. Think 72 hours. Think I need to get on top of this as soon as I can, as quickly as possible. When you've done your assessments for this person, it's quite possible that their distress and their symptoms are sitting up in the moderate to severe categories. And we don't want to leave people in that phase for a long time. So we try to get on top of it as soon as we possibly can. With the deteriorating phase, again, it's about care planning. Have you anticipated the needs for this particular person? If they're going downhill, have you got everything in place that you need to, from a family perspective, advanced care planning, from a medication perspective, if you believe that they're moving to a terminal phase? Have you anticipated all of their care needs? So if someone is deteriorating, it's an opportunity to review their care plan before they become unstable. If the person has moved into a terminal phase, this is indicative of the last days of life, and therefore the terminal phase trumps all the other phases. If that person has moved into a terminal phase or last days of life, things that you need to make sure of is that all of the things that were discussed, all the wishes, all the care needs, all the distress issues have all been addressed, and that your care plan reflects a completely comprehensive approach to the end of life of this person. So, unstable, think urgent. Terminal, think this trumps all other phases, and these 2 need to be addressed as quickly as you possibly can. So why do we love the phase? We love it because it's dynamic. Its allocation is always guided by the care needs of the resident and their families. Once you've done a full clinical assessment, you have then completely holistically reviewed your residents' care needs, and then you're able to allocate phase. The allocation is always based on the care needs of the resident. That's why phases are called stable, deteriorating, unstable, or terminal, because as the name suggests, the actions should match the care needs and response required. The phase is a great triage tool to aid with prioritization and escalation of care, and it informs good planning, which is based on your residents' care needs, and it's responsive to those needs. Phase will help you to prioritize care planning and inform the details within the care plan. And finally, phase is centered around meeting the palliative care needs of both the resident and their families. When you're working with the 4 phases, the 2 that are urgent and require rapid responses are the unstable phase and the terminal phase. If your resident is in an unstable phase, it would mean that in your assessments you have observed that they've got moderate to severe symptoms, and that these are not being managed with the plans that are currently in place. This would involve an escalation to a prescriber and a review, and a new care plan put into place with an ongoing assessment using the full clinical assessment. If the resident became terminal, this phase trumps the other phases. At this point, then, you would consider all the actions required or associated with putting the person on an end-of-life, terminal, last days of life care plan, including involvement with the family. The other two phases in the 4 are the deteriorating and the stable phases. It is quite possible to have someone in a stable phase in outcomes. We see in many instances that people can become rapidly unwell with a delirium, for an example. So unwell that they go from being unstable to even terminal and maybe put on an end-of-life care pathway, and then they recover. That person may, after a few weeks, then reach a point of being quite stable. And this is where you'd consider putting them back into the profile collection for a regular 3-monthly assessments if they've stabilized enough. In the background, you can often see that there's someone who's deteriorating, perhaps a bit more rapidly than the slow deterioration that's often associated with, for example, chronic illness and dementia. This person may have reached a point where they're no longer mobilizing, no longer eating, and they are deteriorating, but they're not unstable and they're not terminal at this point in time. So once you have completed your full clinical assessment, when you're thinking about which phase to allocate your resident, the question to ask yourself is, does this person's care plan need changing? And if your answer is yes, how urgently do I need to act to make these changes? So the main purpose of phase is to manage the symptoms of distress. It's about care planning and the residents' and families' needs. All of those things contribute to how phase is allocated. So thank you again for watching this particular clinical bite. I hope that it helps you to understand phase. If you require any more information, please have a look at this slide. There's an email contact. Thank you. Bye.